We're talking to Dr. Carl Ward. He's the chairman of the National Asthma Program Steering Committee. And this year, their team is uncovering asthma misconceptions. And we're glad to have you here, Dr. Ward. What is the role of the function of the National Asthma Program Steering Committee? What are you trying to achieve?
Okay, so years ago it was determined that we had a lot of problems in Barbados with asthma, and indeed we still do. And different people within the Ministry of Health were doing things maybe a bit piecemeal, here, there, and so on. So it was determined, and this is as far back as 2002, that we should have something central. And the National Asthma Program Committee is just a small subcommittee within the Ministry of Health, made up of some polyclinic staff and also hospital staff. And what we try to do is improve education for asthma within the public health system and also the broader community.
This year, it is uncovering the misconceptions about asthma. What are those misconceptions?
I think one of the main misconceptions is that asthma is mild, and an asthma attack is a slight something that will just ease off, and that's not the case sometimes. The other misconception people have is that asthma is only wheezing, and that an asthma attack is only characterized by somebody actually wheezing and being short of breath, when in reality the most common asthma symptom is actually a nighttime cough, a dry cough, right? So I think those are some of the main misconceptions we have, and from those two misconceptions, a lot of the bad behavior and less than ideal practices that we see tend to stem from those. There are others, but they often tend to stem from those, right?
Talking about misconceptions, a lot of people have their own ideas about what asthma is. From a medical perspective, what is asthma and what causes it?
Okay, so asthma is probably multifactorial. I don't think even now all the scientists in the world have yet been able to properly categorize. And as with all things scientific, the more we investigate, the more you find out. But in its basic sense, asthma is a condition of long-term or chronic inflammation within the lung, within your airways in your lung, and also coupled with what we call bronchial hyperreactivity. What that means is that those same airways are hyperactive and easily irritated. So you have this underlying swelling and irritation, and then at points when something triggers it, be it your asthma trigger, whatever it happens to be, dust, smoke, fright, temperature changes, whatever it happens to be, that then some of those airways which are lined by muscle can then contract and tighten up. And if you tighten up and you are already partly blocked with swelling and mucus and so on before, then you could understand why someone with asthma will have problems breathing. So asthma is some long-term chronic inflammation and reactivity to the airway with intermittent occurrences of that what we call bronchospasm or bronchoconstriction, where the airways tighten up. And that's where then people get the wheezing and the chest tightness and the shortness of breath.
What would you recommend to people who are asthmatic or who have been diagnosed as asthmatic? How would you suggest that they handle their situation? Is every situation different? Is every situation the same?
Well, every situation is different. The first thing people need to do is make sure they actually have a diagnosis and they're not walking around with a hearsay diagnosis or a supposed diagnosis from when they were a child. Oh, somebody told me I might have it. And then for the rest of their life, they're saying that, right? So it's important that you see someone, starting with polyclinic doctor or family physician, or even going all the way up to a respiratory specialist, just to make sure, is it really asthma that you have? And there are tests that can be done to prove that. Now, once that is your diagnosis and it's asthma, then the main things would be common sense things. Try to avoid your triggers where possible. Use the medications as have been prescribed. Make sure you're clear as to what the medications are for. Frequently, we have people using long-term medications, what should be their controller medications, and they're using them when they're wheezing, and then they complain that it's not making a difference. Or they're using the reliever medications like Ventolin and the blue inhalers, and they're using them all the time and not using the controller medication. So you have to make sure you're using them correctly. The other thing is you should try and see your physician. So one of the problems we have here is, despite free health care, fantastic medication, free on formulary, we get people who come here as by the way. You know, somebody's come, they've stumped their toe. And when you're dealing with the stumped toe, then they say, oh, I also want my asthma medicine. And when you check the notes or whatever, then it's like they haven't come for it in like 2 years, right? When COVID first hit and we had our first lockdown, and I remember you would have seen all the massive lines of people coming for repeat medication. Everybody was frightened. But some of these people coming for repeats, and not just for asthma, but some of these people coming for repeats hadn't been by us for like 5 years and 6 years. You know, that's not a repeat. You know, it's not a repeat anymore. So you need to make sure that you're taking the meds as prescribed. Now, the other thing is, one size doesn't fit all. So back in the day, people might have been given a particular prescription, use these inhalers, this is how to use it, and that used to be almost written in stone. And every time they come back, same dosing. But asthma is fluid. Sometimes you need less medicine than that because your asthma is doing well. And other times you need more meds than that because maybe there's dust, maybe there's volcanic ash, maybe there's Sahara dust, maybe there's smoke, and all the illegal burners who can't seem to do without burning stuff every week. You know, something is making your asthma worse, at which point your baseline prescription probably is not the right amount. So your dosing really should vary, and you can vary it with your physician, as in call your physician and say, well, I'm having these problems, and the physician can advise, well, okay, step up this 3 times a day or step down that, make changes. But the other thing, and the ideal thing, is to reach the point where you have what's called a personal asthma management plan, where there's a little set program that you work out with your doctor as to how to vary your medication as is necessary based on your symptoms and based on your situation. So indeed, one size doesn't necessarily fit all, but you're only going to get those sort of things if you keep your appointments and you see your physician, and you don't just turn up for prescriptions and go along.
You talk about some of the triggers.
Yeah.
Let's talk about the indiscriminate burning, which you mentioned just a while ago.
Right, yes.
What is your committee going to be doing, or have you all been doing about that? And especially, you say it's working within the ambit of the Ministry of Health. How have you all been able to influence the Ministry of Health in dealing with that situation?
Okay, so we, along with some concerned citizens, I can't remember their group, there's actually a group who are firmly against this indiscriminate burning phenomenon in this country. We would have pushed the Ministry of Health this for years to try to get this legislation through. Now, what's happened in the past year or so, if I recall correctly, is that, as far as I know, is now illegal to burn stuff unless you have sought permission from the fire service. And obviously the fire service is not going to give you a willy-nilly thing to burn. The other thing that has changed in the past few years is back in the day, certain cuttings and other garden waste and so on, lawn clippings and what have you, back in the day you could not just dump those with SSA, and that was also something that drove people to burn. But now most of that stuff, if not all, SSA takes away. So with those two things, we would have expected a lot of improvement. At least for my neck of the woods where I live, I've seen some improvement, but there's still some people that burn. And I think the next step needs to be more of on the enforcement end, and some of the persons doing that probably need to be called in, right? Called up, and we see them, high up in our newspapers, right?
We've had two situations. One that's been dominant over the last year, and one that has only happened in the last couple of weeks. We're talking about COVID-19. We're talking about the ashfall from the
Right.
eruption of the La Soufrière volcano.
Yes.
How have those two things impacted from what you've seen? Talk to us about COVID, and then you could probably talk us about what's happened over the last couple of weeks.
Okay, well, COVID, first of all, as I would have mentioned, when COVID came, there was obviously mass hysteria and fear among everybody with asthmatic diagnosis, whether a real diagnosis or incorrect or layperson diagnosis of asthma. So as I said, we would have had people suddenly turning up for inhalers that they didn't use at school, and that sort of thing. So we did have a lot of that, and also everybody saying they're asthmatic so they could get through quicker in the clinic and so on. But where it has made a difference, besides making people come and get their inhalers, it's also made a difference in that one of the other drivers for asthmatic attacks is respiratory infections. So not just COVID, regular cough and colds. And mask wearing has made a massive difference. From what I can see, I mean, we don't have scientific numbers at present, but it has made a massive difference in the past year for the amount of run-of-the-mill cough and colds that we see, right? So a lot of times what would happen is somebody is probably not using their inhaler, specifically their preventing inhaler like they should. And then something external triggers them to have what we call an exacerbation or attack. So that could be your indiscriminate burners, or the nearby machine shop, right? Or frequently a cough and cold, a respiratory infection. Now that we're not seeing much of those, and not just because I think they're hiding because they don't want to get swabbed, but now that we're seeing a lot less of those, we're also seeing a lot less asthma attacks, even with all the dust and so on around. The other thing I think that's important for people to understand with COVID and asthma, and the majority of chronic illnesses that are a problem with COVID, is that, truth be told, they're only a problem if they're uncontrolled, most of them, right? So the diabetes and the asthma and hypertension and all of that is normally the people who are uncontrolled, who are not using the medicine, not seeing the doctors. It's more often those people who have the biggest problems, right? And I think the past year, I think people should be able to see that, right? That, trying to do what you're supposed to do, plus taking all our COVID prevention measures, should help you out. The ash did pose a problem for asthmatics, but also for non-asthmatics. There are a lot of people who wheezed because of the ash and had to get inhalers. People who never had inhalers in their life needed inhalers at least short term. We even here at my clinic, we had members of staff who I had to give inhalers to, right? Because of the ash. Now, on a polyclinic basis, because of the risk of nebulization for COVID and if anybody's seen nebulization going on, when you have all the gases all over the place, that's life or death. Otherwise, we're not going to nebulize you. If you come in here wheezing, we're going to make you use your regular inhaler, especially since many of the people who present with wheezing have actually not used anything. They're out of their meds, they don't have the meds on them, They just came to the clinic without using their medication first, that sort of stuff. So sometimes you can just give them the reliever and say use it and watch them, and a lot of times they will resolve like that. And if not, then we use it with a spacer. Now what that has meant though is that people who've actually had full-blown asthma attacks though are largely go down to the QEH now, right? If they really need a nebulization, then if that's going to be done, that'll be done at QEH. But even in QEH, they are largely going to be doing the spacer method. But with all of that said, despite all the other things, the Sahara dust, COVID, and this volcanic ash, seeing a lot less asthma attacks in the clinic. And I attribute it to mask wearing, social distancing, and also people actually getting their medications, and maybe a few people being frightened enough to use them for a change.
That brings us to a question about the numbers or the demographics of asthma and the death rate as well too, from asthma in Barbados. What's the current picture?
Oh dear. I wish I could answer that specific question for you. That's something I can try to get back to you on. Our challenge in Barbados with regards to death statistics on asthma is that for years our death stats lump asthma and a whole bunch of other respiratory illnesses in one, just one lump. And unless there's some really dramatic, sad situation that goes on, like years ago when one of our journalists died from a lot of times people don't know specifically, well, we had this amount. There's not been a proper count. Recently there was stuff in news and social media about somebody who allegedly died following the volcanic ash. I don't know the full details on that one. There was somebody then did tell me just the other day that no, it wasn't that, but we don't know. And too often it boils down to stuff like that, the sensational stories and the sensational possibilities. What we at the steering committee want is we want to have a situation where we can get the stats much better. Throughout the polyclinic system, we now have an electronic medical record, and one of the main selling points of that one was that this medical record system would allow us to pull up stats on things like that. Plug in asthma, see how many visits. Plug in exacerbations, see how many come up, and actually break that down by demographic, age, and that sort of stuff, so that we wouldn't be relying on the 1993 data. There was a study called the ISAC study. There were 3 phases of it. Some of them were done in Barbados, and that is where we got some of the figures that we still talk about, like 20% of school-age children having asthma and so on. We are hoping that very soon, right, once we can get, the shackles of COVID off and be able to do some more work on these NCDs, of which asthma is one. People forget that asthma is one. It's not just diabetes and high blood pressure. That we can have our electronic record system set up to pull reports on asthma, right? Asthma visits, exacerbations, treatment, right? We're really hoping that we'll be able to get that done.
How much would you estimate the cost of asthma treatment to the government of Barbados at the present moment? Would that be something you would have a figure?
Not off the top of my head. That's something that I could get some of the figures in a few days if necessary. One of the things we did, again, because of the paper notes system and so on at the hospital and the difficulty working with that, one of the things that I would do from time to time is I would collaborate with Asthma Emergency, find out how many people they've seen, and also with pediatrics, and get an idea in a particular quarter how many asthma admissions they had. And then the other thing that we would sometimes look at is we would go to drug service and check on their sales of particularly the inhalers, the reliever inhaler, or I should say the reliever medications, right? Be it inhaler or syrup or what have you, and also nebulizing solution. And that for sure can give you a dollar figure as to how much you've used. But suffice to say, in the years, millions. Suffice to say that it's definitely millions, and it's more expensive the more uncontrolled somebody is, because an exacerbation that requires hospital and hospitalization and repeat visits and so on is always going to be more expensive than somebody doing the right things and using their preventer inhaler.
And your final advice for asthmatics as you focus on asthmatics this week?
Yes, so my final advice, let's see. First, try to avoid your triggers. If you know what your triggers are, please try to stay away from them. You have COVID around, please continue the mask wearing. Not only will it protect you from COVID, but it will protect you from this dust to some extent. It will also protect you from the respiratory infections that trigger asthma attacks. Finally, use your inhalers as prescribed. Keep your reliever on you and get a personal management plan from your physician to vary your care as your care needs to be varied.
All right, thank you very much, Dr. Ward.
You're most welcome.